Good afternoon. My name is Dr Lawitschka from the St. Anna Children's Hospital in Vienna, Austria, and together with Hildegard Greinix from the Medical University in Graz, we would like to share our approach how to treat acute GVHD in 2021. I do not have any relevant conflict of interest to declare. So in our recent understanding, the complex pathophysiology of acute GVHD can be conceptualized as a three-step model with first conditioning associated tissue injury, inflammation and activation of APCs, followed by donor T-cell activation, expansion and trafficking, which leads to target organ tissue damage. Recent gained insights demonstrate the multiple layers of the yellow immune response which lead to GVHD. First, chemotherapy, irradiation and infection cause tissue damage with the release of DAMs and PAMs, and further activation of the innate immune cells lead to activation of cytokine cascades with priming of allo donor T cells and expansion of, and trafficking to lymphoid organs and host tissue. So effector cells then, via the production of cytokines and chemokines, cause tissue injury in the host and further immunopathology and GVHD. So acute GVHD is the main serious complication of transplantation with a significant impact on survival. So there are common acute GVHD grading system like the Glucksberg grading and the EBMT grading. Recently, the Mount Sinai group published or introduced the MAGIC grading system. The MAGIC grading system includes more precisely defined symptoms with more detailed criteria, especially regarding grade 4 stage GVHD of the skin, the upper GI tract and the lower GI tract. So what are our treatment goals? Clearly, we are aiming for complete resolution of organ manifestations with limited treatment-related toxicity. This aim should come at the lowest cost of cure, meaning that we want to maintain or have to maintain the maximum GVL effect with minimal impact on the immune system and a minimal impact on infectious complications. This should result in improvement and reconstitution of best possible functional capacity and multidimensional quality of life. So first-line treatment are corticosteroids applied applied in the lowest effective dose and the shortest possible duration. The introduction of first-line therapy should be based on a tailored approach, taking into account the malignant underlying disease. Christina Peters and the Forum Trial Group published in GCO in 2021 that they could see a higher probability of event-free survival in patients with acute GVHD grade 2, emphasizing the GVL effect. So secondly, this tailored approach should take into account the organ involvement and the GVHD grade, and also the infectious risk profile of the individual patient. So in malignant diseases, grade 1 acute GVHD includes topical treatment. In grade 2, with isolated skin or upper GI tract, the treatment should be 1 milligram per kilogram methylprednisone, and for all the other grades, 2 milligram per kilogram per day methylprednisone or an equivalent dose for 7 days is the first-line treatment in acute GVHD, which many recommendations agreed on. As outlined by Cuvillier and published in Blood 2019, we should keep in mind that acute GVHD, multi-organ acute GVHD grade 2 to 4 is the major risk factor for chronic GVHD. As topical treatment of the skin, corticosteroids, tacrolimus, pimecrolimus can be applied. A comprehensive ancillary therapy with moisturization and, if necessary, occlusive treatment should be introduced. The topical treatment of the gastrointestinal tract may be oral beclomethasone or budesonide in a non-absorbable form. In general, corticosteroids are in use with calcineurin inhibitors with the measurement of the blood level weekly. Most guidelines recommend a higher dose and a higher blood level in the first 4 weeks, so 200, and followed by a target level between 1 and 200 in the following weeks, but no detailed consensus exists. However, in adult patients with acute GVHD, a level of over 200 has been published. So what are the details in the pediatric daily routine? When we surveyed daily clinical practice by a pediatric diseases working party study, we found that the relapse risk of malignant diseases does shape the GVHD prophylaxis. With an earlier discontinuation of cyclosporin A when compared to mostly adult recommendation, and of note, in non-malignant diseases, the duration of the cyclosporin prophylaxis was reported to be distinctly longer. Regarding the target levels, the majority of centers reported a lower target level than 200, and a higher induction level was not in use. The duration of cyclosporin A prophylaxis was reported shorter when we asked for the relapse risk. So in high relapse risk in malignant diseases, the duration was significantly shorter, between day 60 and day 120. Furthermore, the cyclosporin A was tapered before day 180 in most centers. So, do patients benefit from an earlier treatment? Andrea Bacigalupo et al. Could show that there is no superiority if you treat earlier. This was published in Hematologica in 2017. Thus, a higher dose higher than 2 milligram per kilogram work better for the patients. There was no advantage seen, but an increased rate of infectious complications in the study of Maria Theresa van Lint in Blood 2006. May patients benefit from a lower dose than 2 milligram per kilogram? Milkarek et al. Reported that only patients with a grade 2 acute GVHD, meaning skin only or upper GI, could be treated with a lower dose, and the management plan has to include topical treatment. The next question is, can we taper steroids earlier? A rapid taper after 14 days seems feasible, but regarding the long-term effects, steroid side effects, no difference was seen between the early taper and the regular taper as published by Hinks. So, however, there is an urgent need for harmonization. In general, it is recommended to avoid high-dose steroids for a prolonged time, but no detailed consensus exists. The EBMT recommendations state that after 4 weeks, 10% of the induction dose may be reached, as published by Olaf Pennock. Paul Martin reported in Blood 2020 a taper of 0.2 milligram per kilogram every 5 days. Again, in daily practice in pediatric centers, the majority of pediatric centers reported to start the taper after 1 to 2 weeks in case of good response. Again, we found various treatment schedules, but mostly the taper was 20 to 25% every 3 to 7 days. Anyhow, the taper of the steroids has to be accompanied by close monitoring of the patient. So summarized, treatment decisions would be supported by a tailored approach, which should take into account the response to treatment, the grade, so the severity of the acute GVHD with the organ specific involvement, the risk of the relapse, and the risk for infectious complications. So there are well-known pros and cons of the steroid treatment, but new concerns are postulated. So steroids may interfere with the immune regulatory processes. So it was shown that absence of FOXP3 responses have been reported in the patient group with higher doses of steroids, and steroids may interfere with antibacterial peptides and may impair skin stem cells. Recently, the interference with the microbiota composition is of special concern. So, is there a rationale for a combined treatment approach? In a study published by Bolanos Meade, the treatment of steroids plus steroid versus steroids alone showed no benefit. This was true regarding the rate of complete response, and also true and mirrored in the survival rate. In another study where published by Alusi et al. In Blood 2009, steroids were combined with either etanercept, MMF, dinileukin, or pentostatin, and there was no advantage seen in the complete response rate, as you can see here, and in the survival at 9 months, but importantly, the rate of infections, there was a high rate of infections, mostly seen in the dinileukin and pentostatin and etanercept group. In another study where steroids were combined with itacitinib versus steroids alone as initial treatment, again, there was no change in 6-month non-relapse mortality. So summarized, the combination of steroids with other treatment options in the pre-ruxolitinib era did not result in a better response rate or in a lower non-relapse mortality. So while steroids alone or in combination with a calcineurin inhibitor have remained a standard of care as initial treatment over decades, only 30 to 50% of patients respond to this initial therapy. John Levine et al. Reported in BBMT 2010 very nicely that the response to first-line therapy corresponds with a higher non-relapse mortality and a worse survival. So the next question is, what is the definition of steroid-resistant acute GVHD? The NIH, CIBMTR, and EBMT task position statement stated, or experts agreed on the following definition. Steroid refractoriness or resistance would mean a progression of acute GVHD within 3 to 5 days if the patient is on a sufficient prednisone or methylprednisone dose of 2 milligram per kilogram per day, or a failure to improve, so no stable disease for 7 days, or an incomplete response after 28 days. Steroid dependence means that you are not able to taper prednisone, or the GVHD flare occurs during taper of steroids. And steroid intolerance means that there are unacceptable toxicity due to the steroids. So which of the patient is at high risk? So which acute GVHD patient is at high risk for non-relapse mortality? This question could be better answered if we look to the newly approached risk scores and the application of biomarkers. Macmillan published first in BBMT 2015 and followed by a validation study published in Hematologica in 2020, the Minnesota Risk Score. This is a clinical risk score which defines the criteria for standard risk and the criteria for high-risk patients. The Minnesota Risk Score defines patient subgroups which will respond poorly at day 28 of response and which have a higher TRM and a higher overall mortality. For the sake of the time, I will not go into details, but I recommend to watch the free web-based program of the Minnesota Risk Score. So what are possible further candidates to identify patients which are at risk for a high-risk acute GVHD? There is the E-6 score, which includes the LDH, the creatinine, and the platelet count as a score about endothelial activation and stress, published by Luft in Lancet Hematology 2017, and the amphiregulin as a marker of tissue Tregs in late acute GVHD, published by Holton. So the next prediction of GVHD outcome is the prediction by a biomarker score, which was published by Levine in Lancet Hematology 2015. The Mount Sinai Acute GVHD Consortium, MAGIC, identified elevated ST2 and REG3 alpha as biomarker, which may predict the poor response to treatment and a high non-relapse mortality. The MAGIC algorithm, which combines the two biomarker ST2 and REG3 alpha into a single value that estimates the probability of lower overall survivor and worse non-relapse mortality for an Ann Arbor staged acute GVHD at 6 months. The map reflects the GI crypt damage and serves as a liquid biopsy also throughout the disease course and may be tested at repeated time points. So how is our model for an individualized risk-adapted approach? This model combines clinical and laboratory tests. First, it should take into account the kind of underlying disease, so that in malignant underlying diseases, we have the need of graft versus leukemia effect, and we have to take into account the level of MRD. In non-malignant diseases, acute GVHD should be avoided in any case because there is no need of graft-versus-host disease and graft-versus malignancy effect. Regarding the patient, the age and the medical history with comorbidities and toxicities has to be taken into account, and also the compliance of the individual patient. Further on, the biomarker are an important point, and as outlined before, the phenotype of acute GVHD with the organ-specific involvement and grade, the onset type of acute GVHD, and the risk score. The risk of infection with the history of severe infection and the CMV status and the ongoing viral load is of importance. And last but not least, the kinetics of engraftment and the chimerism should be considered. So if we consider the risk of relapse, we should avoid over-immunosuppression, which means substances with a potentially increase of the relapse risk, like calcineurin inhibitors and MMF, may be avoided in a special subgroup of patients. Regarding the infectious complications, some agents are associated with higher infectious risk, like, for instance, for ruxolitinib, the bacterial and viral infections, for the TNF-alpha antibodies and MMF, especially viral infections, and for ibrutinib, bacterial and fungal infections. Regarding the comorbidity, agents with side effects in already impaired organs should be avoided. For instance, calcineurin inhibitors in patients with renal insufficiency and ruxolitinib in patients which do suffer already from pancytopenia. The phenotype of GVHD with the risk score or possible overlap symptoms should be considered. And another point could be that the history of the applied agents, especially in late acute GVHD or recurrent acute GVHD, the history should be considered. So we try to avoid treatment options which already failed or which were already associated with unacceptable side effects. So the next question is, how should we treat steroid-resistant acute GVHD? What are the treatment options for steroid-refractory GVHD? Therapeutic options for steroid-refractory acute GVHD are often used with original immunosuppressive agents. There is a wide choice of agents, but except for ruxolitinib, no of the other agents has been approved. The recent approval of ruxolitinib for the steroid-refractory acute GVHD has changed the landscape of interventions for this indication. Ruxolitinib is a selective Janus kinase 1,2 inhibitor which reduces the proliferation of effector T cells and suppresses the pro-inflammatory cytokine production. The study published by Saiza et al. In 2015 demonstrated an impressive overall response rate of 81% and a complete response rate of 46%. The median time to response was 1.5 weeks with an excellent 6-month survival of 79%. Side effects were CMV reactivation and severe cytopenia in 33%. The REACH-1 study was a multi-center open-label single-arm phase 2 trial offering the treatment with ruxolitinib 5 milligram per kilogram twice daily in addition to methylprednisone 2 milligram per kilogram and day. Across all patients, the overall response rate in REACH1 was 55% at day 28, with a median time to response of 7 days and a median duration of response for 345 days. Among the day 28 responder, the estimates of the event-free probability were 81.6% at 3 months and 65% at 6 months. So REACH1 showed a nice overall survival at day 28 with 73% at 6 months and still 66% at 12 months with a low non-relapse mortality rate, but in the other responses the results were less favorable. So in the following REACH2 study, the safety and efficacy of ruxolitinib versus best available therapy in steroid acute GVHD was studied. This was a multi-center, open-label, and randomized trial with the primary endpoint, again, the overall response rate and at day 28 and the duration of the response. The overall response rate at day 28 was 62% versus 39% in the control arm, with a lower overall response rate at day 56. The response rate at day 56 was 39.6 versus 22% in the control arm. The duration of the failure-free survival was clearly superior with the ruxolitinib group. So what other agents may we use in steroid refractory acute GVHD beside ruxolitinib? There are only 2 randomized studies. The one is the study by Macmillan published in 2007, where they studied the treatment with anti-CD147 monoclonal antibody called the ABXCPL versus the treatment with ATG in steroid-resistant acute GVHD. The overall survival was comparable at day 180 and lower at 18 months. And the adverse events regarding infections and infestations were remarkable. Another randomized study tested inelimumab versus ATG in this refractory patient cohort. The 1-year overall outcome was comparable between the 2 arms but there was a high rate of infection and adverse event for the inelimumab arm. So the anti-TNF alpha treatment as salvage treatment for steroid refractory acute GVHD. When we look at the different publications, we found quite nice overall response rates, but there is a high rate of infections, both bacterial and fungal and viral in most of the studies. Tocilizumab is another possibility of treatment for steroid refractory GVHD. The study published by Trubisky et al. In EBMT in 2011 showed the results of 8 patients with both acute and chronic GVHD and mostly acute GVHD grade 4. The response by day 56 indicated an activity of tocilizumab against refractory acute GVHD, but again, infections were the primary adverse events. Alpha-1 antitrypsin is another treatment possibility for steroid refractory disease. This study was published by Magenau in Blood 2018. The overall response rate at day 28 was 65% with durable responses, and the treatment was well tolerated with a minimal toxicity and a low rate of infections in contrast to the previous presented studies. So the overall survival for those patients which were treated with at least 8 doses was 57%. So steroid refractory acute GVHD may not just be about resistant T cells, but also multiple mechanisms may contribute, such as endothelial damage or loss of immune regulation with a failure to compensate by inducible Tregs and ELC3 damage, then the disruption of the microbiota with panel cell damage and loss of protective commensals, and the epithelial cell exhaustion. So there is a concept of tissue tolerance where immune reactivity and tissue sensitivity is counterbalanced by immune tolerance and tissue tolerance. Reinex et al. Have shown that the positive effect of intensified extracorporeal photopheresis on the long-term survival in acute GVHD was accompanied with a low TRM in the group which responded to the ECP, and this was also reflected in the overall survival in the responder group. An important study published by Chegasia in EBMT 2013 showed the superiority of ECP when compared to an anti-cytokine therapies such as inebililimab and etanercept. The complete response was 54% in the ECP arm versus 20% in the cytokine arm, and the overall response rate was 63% in the ECP arm versus 32% in the anti-cytokine arm. In the multivariate analysis, ECP was an independent predictor of response and overall survival with a lower non-relapse mortality. In a review by Abudal, published in EBMT 2014, the data from 6 ECP studies with 103 patients were reviewed. The overall response rate was 69%, being best in skin GVHD with 84%, then followed by GI involvement or GI tract GVHD with 65%, and being lowest in liver GVHD with 55%. While some studies regarding mesenchymal stem cells showed as treatment in steroid refractory acute GVHD showed no survival benefit, this may attribute to the specific product. Bönig and Bader published the use of MSCs from pooled mononuclear cells of multiple bone marrow donors, the so-called MSC FFMs, so the Frankfurt MSCs, and they could show a response rate at day 28 of overall 82%, and the duration of response at the last follow-up with 51% complete response and 30% partial response. Of note, this outcome was age-dependent, with a worse outcome for patients being older than 80 years of age. This was true for the overall survival and also for the non-relapse mortality. Another treatment approach may be the adoptive transfer of in vitro expanded Treg cells, but further results have to be awaited. As the disruption of the intestinal homeostasis and the microbial ecology in GVHD plays a major role, it has been shown that the loss of the intestinal microbiome diversity via the use of antibiotics and via acute GVHD results in a significantly worse outcome with the emergence of enterococci. So what strategies for the preservation of the intestinal microbiota balance are available? So one possibility may be the limiting exposure to antibiotics with a change in the gut contamination. So instead of cyprometronidazole, rifaximin could be used, published by Weber in 2016. And anyhow, a critical use of systemic antibiotics um, would be a good approach, because it has been shown by Shono et al. That there was an increased GVHD related mortality with imipenem and pipedats, but not with aztreonam and cefepime. So another approach could be the transplantation of fecal microbiota and a targeted restoration of specific beneficial bacteria. Regarding steroid refractory intestinal acute GVHD, a study published by Danilescu in 2018 showed a good overall response rate for vedolizumab with 79%, but of note, a high rate of fatal infections have been reported with 65%. So taking together the knowledge on treatment in steroid refractory GVHD is still limited, as published by Paul Martin in Blood 2020. An informal analysis of prospective and retrospective treatment studies for steroid-resistant acute GVHD from 2012 on showed clearly that older age is associated with lower 6 months survival. Importantly, 9 studies did better. These 9 studies included 2 ruxolitinib studies, 5 ECP studies, and 2 studies using CD25 antibodies. Paul Martin clearly stated that biomarker improve the management of steroid refractory acute GVHD using the magic algorithm probability at the day 7 of treatment, which combines criteria of response with criteria of the Minnesota risk score and in combination with a biomarker value. This map predicts the 1-year non-relapse mortality. So a higher positive predictive value relates to a higher risk of non-relapse mortality. This value, this higher value may allow a treatment with a higher anticipated risk in the future. So as a concluding, what are our treatment and decision making aspects? Treatment of acute GVHD in 2021 should be individually tailored and risk-adapted approach. We do not want to change more than one agent at once, and we try to not combine more than 3 systemic agents at the same time. The patient's compliance and preference should be considered. So, for instance, substances which require a compliant patient should be avoided in incompliant patients. So, for instance, tocilizumab. And in patients which tend to stop medication, IV course could be of benefit. So we try to listen to the patient's preferences. The ease of use and the need for monitoring should be considered with an up-to-date treatment and management plan. Also, the distance to the transplant center may be of an importance. Regarding the national availability and the funding, it is important to avoid financial toxicity. And last but not least, a comprehensive supportive care and a close clinical monitoring, including viral surveillance by PCR, is of utmost importance. So thank you for listening, and we are happy to answer your questions. Thank you.